Afternoon and welcome to Talk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and HOPE assessment data collection issues that matter most in home health and hospice. Talk aims to bring you closer to reliable experts in home health and hospice, and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about falls and the new falls with major injury outcome. And now I'd like to introduce our industry guests for this episode. Today we have OC Advisory Board members Lisa Selman-Holman and Kelly Kavanaugh with us. Thanks for joining us today, ladies.
Thank you.
All right, listeners, before we get the discussion started, if you have any questions for our panelists today, please go ahead and ask them in the chat pane, and we'll try to get to as many as we can. Lisa and Kelly, I know we've got a lot we want to share today, so I'm going to turn things over to you, and just let me know when you'd like me to advance through each slide.
Okay, so we're going to talk about falls and the new falls with major injury. So we have some changes to the falls definitions themselves, and then we have a new outcome we need to talk about. The next slide. So the background is approximately 20 to 30% of older adults, and they're counting older adults as greater than equal to 65, experience one or more falls each year. I'm one of those that experiences one or more falls each year. Unfortunately, these falls are associated with substantial burden to the healthcare system, individuals and families. We have injuries, fractures, reduced functioning and quality of life. So it becomes a major public health concern because of the $30 billion in direct U.S. healthcare costs annually, as well as immense psychological and physical impacts of falling. The fear of falling becomes even greater than the fall itself sometimes. Evidence from national surveillance data and the research indicates falls are the leading cause of injury-related death in persons aged 65 years or older. This is one of the reasons why functional mobility is so important for our outcomes and so much a part of value-based purchasing. Next slide. So the OIG, that's the Office of Inspector General, I've always referred to them as a fraud police. They did some recent studies found substantial underreporting of falls with major injuries and assessment data. So in other words, the patient failed, they have major injury, they were treated for the major injury, but our assessment data, our OASIS, did not indicate either a fall, or maybe it said a fall but did not count as a major injury. And they specifically cited that approximately 50% of falls with major injuries are not reported across settings. So this is not just a home health problem, it's also a nursing home problem. So in 2020, Sangavi found that only 57.5% of claims identified falls with major injuries events were reported in MDS assessments by skilled nursing facilities. So it's not only home health. But this 2023 report, I do suggest that you find that 2023 report and take a read. It's very, very interesting. They reviewed falls in the home health setting, and they found that only 45% of claims identified falls with major injury events were reported by home health agencies and outcome assessment information set data. So in other words, only 45% of these falls with major injuries were actually reported by home health agencies in their OASIS. They additionally found that those agencies with the lowest scores, as reported on Care Compare, in other words, those ones that just look like fantastic because they don't have any falls, tended to have the highest levels of underreporting. So that's significant because to the OIG, that means that we're not reporting our falls. We don't want to report our falls. We don't want anybody to know our patients fell. And so they're thinking, what is going on here? Next slide. So Kelly?
Thank you, Lisa, for setting the stage for that. It's important, and they're digging, and they're going to find things when they dig. They always do. So what do we need to do about it? Well, we need to pay attention to how we're answering our OASIS items. That is the single best thing that we can all do to get out from under the microscope of scrutiny, right? So let's talk about the OASIS items that we have concerning falls. We have 2 of them. One of them is the J1800, which asks simply, were there any falls at all? Any falls at all since the start of care or resumption of care, whichever is more recent. So we got to pay attention here. We got some time frames we're talking about. So these questions are asked at transfer death at home in DC. And so they're wanting to compare that time frame from the last start of care or resumption of care, whichever is more recent, to the current time that you're filling out the form today. So they're looking at these pieces of time. So they're wanting to know any falls at all in this item. So this is simply, the 1800 is simply a yes or no. When you jump down to 1900, now you've got to qualify those. So if you said yes, you had a fall in that time window that we're talking about for that OASIS, then you have to say, based on however many falls you had in that time period, did you have no injury falls, did you have minor injury falls, and did you have major injury falls? And we've got some definition changes for all of these things as well. But it's important to kind of wrap your head around here at this point before we jump into some of this on what we're talking about with these items. So 1800, any falls, and then your 1900 of those falls, what happened, right? So that's the thing. And so we have to pay attention to these time frames. Okay, next slide, Jan. All right, so some scoring tips we need to talk about for 1800 and 1900 before we talk about new definitions and things. Let's kind of wrap our brain around what we're talking about here. So reported falls that occur at any time during the quality episode need to be reported regardless of where the fall occurred. So if the fall occurred somewhere other than in the home, but you're still in your quality episode for home health, we have to count that. So we're not just talking about falls that happen in their place of residence. So if they fall at the doctor's office during your time with them, that would be reported as a fall. So it doesn't matter where it happens. We're going to talk a little bit about some definition changes for intercepted falls, because they are considered falls. And they may or may not result in an injury, but they're still considered a fall. So just because they didn't hurt themselves, that doesn't mean you don't have to count it as a fall. So the fall that occurred at the doctor's office while they're on your service, they're in the middle of a quality episode, would need to be reported. A fall that occurred during a qualified inpatient facility transfer. So if they have already been transferred, they're in the hospital, and then they fall in the hospital, they would not be reported as a fall on your next time that you have to answer this question, because they didn't fall while on a quality episode. Because remember, that quality episode begins with the start of care or resumption of care and ends at transfer, death at home, or discharge. So if you have done a transfer, the patient is not in a quality episode anymore until you do that resumption when they come back. So if they fall in that window, then that's not on our watch, right? So kind of wrap your brain around that for a minute. One other little thing I want to mention while we're on this slide, a major injury that gets confirmed after you completed your transfer is still, you need to be sure that you're capturing that correctly on your transfer. So I'm going to point out an example here. Let's say your patient falls. You send them, they go to the ER, their first x-rays that they have done at the ER, they don't show any fractures, okay? So, but they have a UTI. So they're gonna admit the patient to treat the UTI. So you fill out your transfer, you say they had a fall, but they had maybe minor injuries from that fall. So you're gonna report those minor injuries because the fractures, the x-ray said there was no fracture. You get ready to do, they tell you, okay, this patient is going to come home. You're going to do your resumption of care, but they tell you, oh, this patient did have a fracture after all. They did a CT scan on day 2 of their hospital stay, and they discovered that, yes, this patient did have a fracture from the original fall. So guess what? You may have already completed your transfer. You may have even submitted it to CMS, but you submitted it with only a minor injury. You need to fix that, because that fall happened on your watch. It happened during your quality episode, that fall that caused that fracture. So that would need to be reported as a major injury, not a minor injury. So you would need to pull that transfer OASIS back and fix that and resubmit it. So I hope that makes sense. And I think that maybe some of the times that we may be accused of underreporting or not reporting false, because we didn't answer that question correctly, because we found out the information after our time window, but that does not mean that that didn't happen on our watch. So we would need to fix that reporting. Okay, next slide. All right, so now let's talk about some definition changes that CMS has given us. All in all, I believe that they did a pretty good job in clarifying some things and changing some stuff up for us, but you just need to be aware of what they did, right? So the definition changes for the falls. We still have the unintended change in position, coming to rest on the ground, on the or on the next lower surface. So keep that in mind as well. If they fall down and they land into a chair, that's still a fall. They still had that intentional, unintentional rather, position change on the next lower surface. It can be witnessed, it may not be witnessed, it could be reported by an observer, or maybe identified just because you found them on the ground. So it doesn't matter if they're witnessed or not, it's still a fall. They have taken out the line, which has been stricken through on this slide. Falls are not a result of overwhelming external force. They have decided that a fall due to an overwhelming external force, like a patient pushing another patient down, would be considered a fall. So that is a change that you need to be aware of. Next slide. Some more changes that we have here is in the injury, what is considered major injury. They have changed up some wording to it's not limited to on our except major injury. So these would be your minor injuries. So they would not be limited to these things, but they gave us a list of possible examples. So they're saying there could be other things that could be considered minor. So don't limit yourself to only these things. So if your patient didn't have one of these, you don't have to report it. They're clarifying that for us here. And then major injury, they have updated that again to the not limited to, and they added the word traumatic bone fractures for major injury here. And that's going to be important to point out. And then they clarified some subluxations with the dislocations, internal organ injuries, amputations, spinal cord injuries, head injuries, crush injuries. They did remove a couple of wording here for clarification for head injuries and altered consciousness and things. They took out some confusing language and made it just a little bit more clear. The fractures confirmed to be pathologic versus traumatic are not to be considered a major injury resulting from the fall. So guess what? We are going to have to find out from the providers whether or not a fracture is considered pathologic or traumatic. So I know when we're talking about coding, for coding's sake, there are some assumptions that we make during coding of whether you code something as an osteoporosis fracture, for example, versus a traumatic fracture. But for the sake of the injury definitions and how we are answering these OASIS items, we're going to have to know what the provider is telling us about these fractures. And are these fractures confirmed to be traumatic or pathologic fractures in order to answer these questions correctly? So it's going to be very, very important to find out as much information as possible. So some new emphasis on accurate information from the providers. Next slide. So here's some examples. These came straight from CMS. So we've got a patient that had a fall, but the physician diagnosed a pathologic fracture in this patient's case. So for 1800, yes, they still had a fall. We can't deny that they had a fall. But what's going to change is your 1900 item, which is the type of injury. The pathologic fracture is not considered a major injury. So if that is the only injury they had, then you would have a no injury fall. If they had some other minor injuries, some skin tears and things like that, which most likely they would, then you would record it under the item B for injuries other than major, for all your minor stuff that may have happened with that same fall. The key in that is physician diagnosed a pathologic fracture. So in the next example they gave us, the patient had a fall and has osteoporosis, but the physician diagnosed a traumatic fracture. So 1800 is still yes, patient still fell, but the difference being the 1900C, you would have that 1 because the patient had a fall with a major injury because it was diagnosed by the physician as a traumatic fracture. Next slide. Couple of things here just to point out quickly, this differences in some terminology and some language that gets thrown around. So we have something called the balance challenge. That's a purposeful intervention used by therapy in their assessments and finding out how this patient is able to handle changes and stumbling and all those kinds of things. So the balance challenge is something that the therapist does to the patient to maintain that postural control and stability during their tasks that they're doing. So they're intentionally testing this patient. So if a patient stumbles or has a near fall during that challenge by a therapist, that's not considered a fall unless they have a major injury because of it. And we'll talk about that in a minute. An intercepted fall occurs when a patient would have fallen, but they actually didn't come to rest on the ground or the lower surface because either they caught themselves and stopped themselves from falling, or another person intercepted and stopped them falling before it happened. So that's not during a balance challenge, that's anytime. So if they have one of those situations, that's a fall. So you got to be asking your patients some questions when you do your assessments to see if any of these things have happened from your visit to visit, because they may or may not tell you these things. So you're going to have to ask some questions. The unexpected stumble is an unplanned loss of balance or brief disruption in gait where a person momentarily trips or nearly falls, but typically recovers without coming to rest on the ground or a lower surface. So similar to that intercepted fall situation are those unexpected stumbles. And that, if that was not planned, if that was not a balance challenge or part of a therapeutic intervention, then that is still considered a fall. So we've got to be asking some questions and taking note of these situations. Next slide. All right, so here's where we're going to start talking about this whole balance training situation. So an anticipated loss of balance resulting from that supervised therapeutic intervention is not considered a fall or an intercepted fall because you're intentionally doing that. However, they have clarified now, and this is a change also from CMS, if a major injury results from this intercepted fall during this balance challenge, then it would need to be reported as both a fall and a major injury for 1800 and 1900. So you would answer yes on 1800, and your 1900C major injury would be a 1 for that fall because it caused a major injury, like a fracture, because of that balance challenge. So that is a change from CMS. So then they gave us a couple of other examples here. A patient is ambulating with a walker and with the help of a physical therapist. The patient unexpectedly stumbles, and then the therapist has to bear some of the patient's weight in order to prevent them from falling. So that for 1800 would be coded yes as a fall, and it would be counted as a no injury fall in J1900A. So there would be a 1 there if you had no other falls besides that. So the rationale that is there for you: the patient unexpectedly stumbled. It was not anticipated by the therapist. The therapist was not doing that to the patient. They intercepted it, but it did result in a loss of balance and stumbling and all that. So it would be considered a fall. Okay, next slide. We have, this is kind of a cool little schematic here. I can't take credit for it. Lisa made this, but it's a nice little schematic that kind of helps you decide if you have an intercepted fall, did it occur because of balance training or not? And then was it a major injury or not? And kind of helps guide you on how to answer those 1800 and 1900 questions, because you do have to think about these. This is not something you can just slap, slap, slap and check some boxes and roll on. You're going to have to think when you answer these based on your patient's scenarios. So that's a good schematic for you. And the next slide, just a couple of notes here about, we talked a lot about 1800 and 1900, but we haven't really talked about M1033. The M1033 also has a fall component. The item number 1 on 1033 is talking about, did this patient have fall? So it has now some similar guidance as to what is a fall. An intercepted fall occurs when the patient would have fallen if he or she had not caught themselves or had not been intercepted by another person. So that's still considered a fall, and it would still be considered a fall on 1033 as well. So we need to be capturing all of those on 1033 if you're not already. So it's witnessed and unwitnessed falls for both 1033 and 1800, 1900. The overwhelming force being pushed down by another patient would be considered for both of these sets of items as well. That therapeutic balance thing sometimes would be considered a fall, like we talked about with the major injury. So that would be the same on 1033. You would still capture that if there was an injury for 1033. And then the intercepted falls where they try to catch themselves. So that would be considered on 1033 and your 1800 and 1900 items. And that was updated with our October 2025 Q&As from OASIS. All right, I'm going to stop talking now and turn it back over to Lisa.
All right, so now we have all the falls down. Let's talk about that falls with major injury outcome. Next slide. Okay, so we have the original version of the measure that we have been living with for a long time, and now we have the new one. And the original version of the measure has been consistent across all of post-acute care, including home health settings. And we're identifying that fall and that major injury from our assessment. Whether we're doing an OASIS or an MDS, whatever setting we're in, we're looking at J1800, identifying that there was a fall, and then J1900 to determine what kind of injury. And when we're looking at the outcome, what we're looking at is major injury from a fall. Now, our new one is more complicated, and we're going to start in the blue box at the bottom because that's our original measure right there. They're going to look at whether we had a fall on the assessment. So they'll look at J1800 is a 1. That means, yes, there was a fall. And then they'll look at J1900C and look for a 1 or a 2. So 1 means 1 injury with fall, and 2 is 2 or more injuries with fall. So that's the step 1. Then they'll go to step 2. And remember, they're doing this because the Office of the Inspector General found a lot of falls that we did not identify in our OASIS. So they're going to look further into claims, and this is not our claims, it's the claims encounters from the hospital, the emergency department, observation stays, those kinds of things. So step 2 is they're going to look for our fall on the assessment, J1800 equals 1. We're going to identify that's a fall, but then they're going to look at the claims from those particular settings, the hospital, the ER, and the observation stay, to see if there was a major injury identified in that claim or encounter. Then there's a step 3. And so we're getting to the yellow box now. So we're looking at the instances where we may not have identified that fall in our OASIS, but there is a fall identified in the claims. And so they're looking at the fall identified in the claim, again, not our claim, the hospital, the ER, the observation stay. And they're looking for that external cause code for fall. So, you know, a lot of us in home health don't even use external cause codes, but the hospitals are, and the emergency departments are. And so they're going to look for that fall in the claims, external cause code, and then they're going to look for that major injury identified in that claim. So they're checking it 3 times, if you will. If we have identified the fall in assessment and we have a major injury on that assessment, they stop. But they continue on. They're looking at all the claims, regardless of whether we identified a fall on our OASIS or not. Very important. Next slide. So the data sources are the OASIS, but they're also looking at Medicare fee-for-service claims, and this is very important. They're also looking at Medicare Advantage encounter data, Medicaid claims and encounter data. So this just not Medicare fee-for-service, it's Medicare Advantage, Medicaid as well. And then there's no risk adjustment on this, by the way. So when people say, well, where's the risk adjustment? They have already fallen so many times, and don't we get risk adjustment for that? No, there's no risk adjustment. There's only the typical OASIS exclusions, the patients under 18, patients maternity, or the patients receiving unskilled care only. Those are the typical OASIS exclusions for any of these outcomes. So again, Medicare fee-for-service, Medicare Advantage, and Medicaid claims and encounter data. Next slide. All right, so the detail on the classification, they're identifying the population, they're looking at quality episodes, and we had the quality episode defined on an earlier slide, but start of care or resumption of care starts a home health quality episode, and then we have an end of care, which is a discharge or a transfer, those end of care. Okay, so they're going to look at the quality episodes, and then they're going to link Medicare and Medicaid claims and encounter data for each quality episode. So if I have a home health episode that starts with a start of care, and then I have a transfer, they're looking at that Medicare claim or Medicaid, as the case may be, for that hospital, ER, etc. So they're looking for a claim. Number 3, they're going to identify falls with a major injury. So they're using those quality episodes and linking those claims and encounter data. So, for example, row 4 on this slide. So we had a fall. The agency did not call it a major injury. J1900C, remember, is major injury, but there was a claim for an injury. So Medicare is going to say, yes, there was a fall with major injury. Look at number 6. This is a problem. The agency did not identify a fall. They did not identify a major injury. However, there was a claim for an injury and it resulted from a fall, according to the external cause data. Okay, so I do want to remind you, when they're looking at these diagnoses, they're looking at the hospital, the ER, observation stay. They're not looking at your diagnoses. So there's no way to manipulate this. They're looking at the claims data from those places that patient went to when they had the fall. And then they're calculating the provider level falls with major injury rate, and that is essentially the number of episodes with a fall with major injury divided by the number of quality episodes. Next slide. Now, the tech specs, known as tech specs, but it actually stands for technical specifications. So there are technical specifications for this outcome, and essentially these definitions match the ones that Kelly already talked about. So injury related to the fall, any documented injury that occurred because of or was recognized within a short period of time after the fall, for example, hours to a few days, and attributed to the fall. The injury except minor, you have your skin tears, your abrasions, lacerations, etc. So that's the same definition we already saw. And then the major injury, this is the one that goes on J1900C. And remember, this is where the falls with major injuries outcomes comes from, is J1900C. So that's where we identify the major injuries. And again, we have the change, but not limited to, traumatic bone fractures, joint dislocations, subluxations, internal organ injuries, amputations, traumatic spinal cord injuries, head injuries, and crush injuries. And somebody's asked, well, what if they had that because they were in a car accident? Well, then the external cause code would be different than a fall. And when you look at this list of diagnoses, those are found in Exhibit B and Exhibit C of the text specs. There's internal organ injuries like injury to the fallopian tube. So they've got pretty much everything covered there as far as a major injury. Next slide. Okay, so these are just a couple of examples, but it pretty much says exactly what I've already been saying. You have a qualifying post-acute care stay episode. Does assessment indicate a fall? If we answered yes on J1800, then they want to know, did J1900C indicate a major injury? If it did, then that was identified with assessment data only. If it doesn't, they're going to match that PAC stay episode to claims and encounter data. And then they're going to say, is a qualifying major injury diagnosis code found to be linked to the stay episode? Yes. Then they're going to identify it with the claims, the counter, and the assessment data. If we did not mark a fall on J1800, then you're on the right-hand side, and they're still going to go through the claims data and match that stay episode to claims and encounter data to see if there's a major injury diagnosis that's also identified as a fall. So you see that first green box on the right is a qualified major injury diagnosis code found to be linked to the stay episode. No, then there's no FMI identified. And then yes is a fall external cause code present on the link claim. If it's not there, then no FMI identified. But if it's yes, then they will identify that as a fall with major injury that will go into your numerator. Next slide. Okay, so there were some concerns because there's a technical expert panel that was involved in coming up with some of this, and they were concerned about a few things that they did not want included in our numerator. So I clarified some of this language just so that it would be clear, because sometimes they talk in outcomes and not everybody talks in outcomes. But one of the concerns was the injury occurred before the home health stay. For example, you're admitting them because they got an injury. We don't want that claim to be counted against us. And so their exclusion is that they're excluding injury codes identified as sequela, and they're excluding injury codes identified as subsequent encounter. So if that injury code is coded on that hospital emergency room claim, for example, with an S on the end or a D on the end, they're not counting it against you. FMI event claim on same date as admission, they will exclude any injuries that occurred on the same date as your episode start date. If the FMI event occurred while in the hospital, they're going to look for corresponding present on admission flags to distinguish whether that major injury occurred while in the hospital or outside that hospital. And then the FMI event occurred following discharge from home health episode/stay. So exclude claims when the from date is greater than the episode end date. In other words, they fell after you discharged them. That one's important to realize that, yes, it's not going to go on your falls with major injuries because you had already discharged them. But if they end up back in that hospital, it goes against your discharge to community outcome. So they get you either way. Next slide. Okay, so this new calculation, so they went through this process with what they're finding with claims and etc. And they have a mean fall with major injury rate of just with assessment of 1.053. With step 2, where they're actually looking at the assessment and looking for major injuries in the claims, it rises to 1.73. And then step 3, it rises to 2.37. Now, interestingly enough, and this is what OIG pointed out, is according to Care Compare data, we have an average of 0.24%. So you can see 0.24% is a lot different than even 1.053, but it's much, much different from 2.37. So what 0.24 means, and that's what the Care Compare was showing, is 0.24 patients per 100 home health stays were having major injuries from falls. And this period was April 1st, 2024 to March 31st, 2025. So this is showing, instead of 0.24 patients, this is showing 2.37 patients per 100 home health stays were having major injuries from falls. So the new calculation shows a different story. And when you look at Medicare or OIG's comment that some of the agencies with the lowest rates of falls were actually the ones who are not actually documenting them. When you look at the right-hand column, percent providers with no FMI events, notice that the number is almost half of what it is just by assessment. Next slide. So that's a lot of information about this outcome, and I think that Kelly and I both want to make sure that you understand what the outcome is, and that they're looking for falls, and they're looking for falls with major injury. And you may say, oh, but I didn't know it was a major injury. I can tell you from experience, if you tell Medicare, oh, but we didn't know because, you know, we only see the patient one time a week and we didn't know, Medicare's answer is you need to keep a better lookout for your patients. So that doesn't really work as an argument with them. But we need to focus on some clinical areas to prevent falls to begin with. And we're identifying the risk for falls when we answer M1033 at that start of care and that resumption care. We identify the risk for falls. If we're identifying the risk for falls and we're asking the falls question correctly, because remember, intercepted falls counts as a fall there, then we need to put into place some interventions from the very beginning. So like, for example, evaluating medications that impact balance, cognition, sedation, or blood pressure. If they have orthostatic hypotension, routinely assess for those changes and address symptomatic drops in blood pressure. Identify vision deficits that limit hazard recognition and depth perception, increasing falls risk. Assess for muscle weakness, gait instability, impaired coordination, and limited endurance that compromise safe ambulation. I know I have fallen and I've hurt my hip, and I do have artificial hips, so I hurt my hip when I fell. Well, then I stopped picking up my leg because it hurt, and guess what? I tripped again and fell again. So you need to, you know, look out for these kinds of things with these patients. Risk-taking unsafe behaviors, those behaviors such as rushing, like rushing to the bathroom because they have a little problem with incontinence, improper footwear, refuse or misuse of assisted devices, and not adherence to safety recommendations. So those are just some ideas for some clinical focus areas to put on your plan of care to decrease the risk of falls to begin with. Next slide. These are our resources. And there's that link to the technical specification report. That's the 5th one down. And then we have the changes to J1800 and J1900, which is the 6th one down. All great information.
Fantastic. Thanks so much, Lisa and Kelly. This was great. It was so nice to get such a thorough rundown of those changes. We did have one question come in, so I will ask it. And the question is, are all the other parameters still required to answer yes for falls on M1033? Single fall with injury, 2 or more falls with or without injury, and falls occurring in the last 12 months.
Those parameters are still the same. Just remember that the definition of falls has changed a little bit. When you're talking about someone pushing or the dog jumping up on the patient, etc., that is a fall now, and it wasn't a fall before. So, and remember those intercepted falls that people tend not to think about or don't tend to ask the patient about, because if you ask the patient, hey, have you ever tried to get up from your chair and then kind of lost your balance and fallen back down to the chair? And they were, yeah, I do that all the time. That's a fall. It may not have ended in an injury, but it's a fall.
Great. Thank you, Lisa. All right, now it's time for our scenario spotlight. This month's episode of OCTALK is brought to you by Decision Health. Oops, I guess I got these things slightly out of order, so let's jump into our scenarios. Apologies. Let's talk about our December scenario. Our December scenario centered around answering M1033 for history of falls. And in this case, the patient had a large bruise on her right arm after falling after her granddaughter ran into her. And we asked you to determine how to answer M1033 for history of falls. And the correct answer is C. Check because an overwhelming external force is considered a fall. So as we learned today, effective January 1, 2026, the definition of a fall for M1033, risk for hospitalization, was updated and defined as an unintentional change in position coming to rest on the ground floor or on the ground floor or onto the next lower surface, such as onto a bed, chair, or bedside mat. The fall may be witnessed, reported by the patient or an observer, or identified when a patient is found on the floor or ground. A fall due to an overwhelming external force, such as a patient pushing another patient, would be considered a fall. And for our January scenario, we have another fall-related OASIS question for you. And in this scenario, the PT is working with a newly admitted patient with a diagnosis of dementia. The patient is using their walker for ambulation, and PT is having the patient stand briefly on one leg and then the other to work on increasing their balance due to an unsteady gait. While standing on the left leg with the right foot off the floor, the patient fell against the counter and immediately complained of right upper arm pain. And the MD was notified. The patient was sent to the ER, where they were found to have a right midshaft humerus fracture. The patient was admitted to the hospital for an ORIF of the fracture. How should the clinician completing the transfer respond to J1800, any falls since start of care or resumption of care, and J1900, number of falls since start of care or resumption of care? And we'll ask you to think about that scenario and what the correct response would be, and we'll share that answer during our February episode of OCTALK. And now it's time for the product spotlight. And this month's episode is brought to you by Decision Health's Face-to-Face Answers. This guide is the ultimate face-to-face reference for agency teams. Learn how the rules and interpretive guidance should be applied on a day-to-day basis to ensure compliance and retention of reimbursement for services. Plus, you'll get pre-claim scenarios, pre-claim audit checklists, and more. And OCK members can save 20% on this book at checkout. So please follow the link in your handouts to order your guide today. And if you're listening to a podcast version of this call, you'll find the handouts on the OCK website under Resources, Free Webinars. And now it's time for What's New with OCK, where we share updates from the Association of Home Care Coding and Compliance. If you are an OCK member, we have a members webinar coming up on Wednesday. So check the January OCK e-zine, which should hit your inbox today, for the link to register. Our January 28 members call will focus on a variety of topics, including recent OASIS updates, COPD and cancer coding, and using other specified codes. And we hope you enjoyed this episode of OCTALK. Thanks again, Lisa and Kelly, for all the great information you shared today. And thanks to all of you for tuning in. Please join us again for our February call when OCK board members Janan Griffin and Sherry Parson will join us to discuss crafting a compliant plan of care. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find OCTALK on your favorite podcast app. Or you can also listen to the recording and access the handouts on the OCK website at ahcc.decisionhealth.com. And if you have any suggestions for future guests, topics, or ideas about the format of the show, please send them along to me via email at jan.milliman@decisionhealth.com. Thanks so much for listening. Thanks again, Lisa and Kelly, and we'll see you all next time. Take care.
Bye, everybody.
Bye-bye.
Bye.